Ever notice those brown spots on sun-kissed skin and wondered if they're just age spots or maybe something more significant?
It's a common sight, definitely.
Welcome to Dermatology Discussions. Today, we're doing a deep dive into two types of pigmented macules you'll encounter, solar lentigines and PUVA lentigines.
Right. They can present quite similarly sometimes.
Exactly, but their origins and clinical implications are really quite distinct. Understanding these differences is, well, it's key for us.
Absolutely. So let's kick off with solar lentigines. These are, those brown macules that pop up after sun exposure.
And they get more common with age, right?
They certainly do. Research shows a clear link with cumulative sun exposure. And it's not just like intermittent bad sunburns,
But
chronic sort of everyday exposure. That plays a big part too.
And histologically, what's going on under the microscope?
Well, there's melanocyte proliferation, similar to a simple lentigo. But with solar lentigines, you also get solar elastosis.
That's the sun damage to the elastic fibers.
Precisely. The degeneration in the dermis. Plus, you see an increased number of photoactivated active melanocytes.
Got it. So, practically speaking, where do we usually see these lesions on patients? Does it vary?
It does seem to vary a bit with age and sex. In, say, younger patients, you might see them on the face, both sexes and shoulders, particularly in males.
Okay.
Then in older individuals, it's often the backs of the hands and the face. Classic spot.
And what do they typically look like?
Clinically, they're macular flat, usually can-colored, but they can sometimes get quite large, maybe with slightly irregular borders.
Right. Now, the crucial part, the differential diagnosis. What else are we thinking about?
Yeah, this is critical. You need to consider simple lentigines, of course, and seborrheic keratoses can sometimes look similar initially.
And the more serious ones?
Absolutely. The big ones to rule out are lentigo maligna and melanoma in situ. That's where careful evaluation and often dermoscopy becomes invaluable.
Okay, dermoscopy. What helps distinguish a solar lentigo there?
Well, while they can share features with simple lentigines dermoscopically, a key clue is often the surrounding skin.
Showing photo damage.
Exactly. You'll see other signs of sun damage around the lesion itself.
What about differentiating from SKs or, more importantly, lentigo maligna using the dermoscope?
Good question. For seborrheic keratoses, you're looking for things like milia-like cysts, maybe those cerebriform, sort of brain-like patterns, and usually quite sharp borders. Lentigo maligna, on the other hand, that might show asymmetrical follicular openings, perhaps an annular granular pattern, pigmented rhomboidal structures, or even obliterated hair follicles. Different set of clues entirely.
And if dermoscopy is still ambiguous, if you're just not sure?
That's when histology is needed, and sometimes even immunohistochemistry can be really helpful in those tricky diagnostic situations. It uses antibodies to find specific markers in the tissue.
Okay, so once we've confidently diagnosed solar lentigines, what's the main advice for the patient?
Photoprotection. Rigorous photoprotection is paramount. It's all about preventing future lesions.
So, sun avoidance, high SPF broad-spectrum sunscreen.
Yes, and protective clothing. Hats, long sleeves, the works. It's important to stress that while the existing solar lentigines are benign, any new or changing spot always needs checking out before we even think about cosmetic treatments.
Right, makes sense. Okay, let's shift gears to PUVA lentigines. What's their story?
PUVA lentigines, well, these are pigmented macules too, but they arise specifically in patients who've had long-term PUVA therapy.
The photochemotherapy for things like psoriasis.
Exactly. These lesions tend to be relatively large and appear after those treatments.
And is there anything particularly significant about finding these?
Yes, definitely. Research has clearly shown that PUVA lentigines are actually a marker for an increased risk of non-melanoma skin cancer in these patients. That's a really key point.
Wow, okay, so that changes the follow-up picture. Do they fade after stopping PUVA?
They can hang around for quite a while, actually. Several months even after therapy stops. Dermoscopically, they often look quite similar to solar lentigines, which can help identify them.
So, treatment-wise, what do we do for the PUVA lentigines themselves?
The lesions themselves generally don't need treatment. The focus isn't on the lentigo itself.
It's more about the underlying risk.
Precisely. Because of that association with increased skin cancer risk, the recommendation is really for regular, diligent skin cancer surveillance for these patients. Long-term follow-up is essential.
Okay, so let's just recap the main differences then. Solar lentigines linked mainly to sun exposure, aging, generally benign, but need careful checking.
Right. And PUVA lentigines link to that specific phototherapy and, importantly, flag an increased risk for a non-melanoma skin cancer, demanding closer follow-up.
So in both cases, careful clinical assessment is vital. Dermoscopy helps a lot, and sometimes histology or even immunohistochemistry is needed for a definitive diagnosis.
Absolutely correct. Accurate diagnosis guides the right management and patient advice.
Which brings us to a final thought for you listening. Considering these distinctions, how might your own patient counseling and perhaps your follow-up strategies evolve for individuals presenting with these different types of lentigines?
Something definitely worth reflecting on.
Thank you for being with us today on Dermatology Discussions.
Our pleasure.
If you liked being with us, subscribe for great content like this.